Good morning, students. The topic of discussion today will be the congenital anomalies of larynx. So the specific learning objectives of today's session will be at the end of the session, students should be able to describe the development of larynx. Student should be able to outline the anatomy of pediatric larynx, describe the clinical manifestations of congenital anomalies of larynx, and then the student should be able to enumerate the common congenital anomalies of larynx and their management. So coming to the development of larynx, we have already discussed about the development of larynx in the anatomy session. So as you all know, the larynx developed from the fourth and sixth branchial arches. At the third week of gestation, the respiratory primordium is derived from the primitive foregut to later form the lung bud and later the bronchial bud, which will eventually develop into tracheobronchial tree. At the fourth and fifth week of gestation, the tracheoesophageal folds fuse to form the tracheoesophageal septum, leading to separation of tracheal airway lumen from esophageal digestive tract. So that's the septum which will separate, and then the trachea and esophagus or the pharynx is separated. So that's the respiratory diverticulum. That's the tracheoesophageal septum. And at the end of fourth week, you can see that there is a separate trachea and a separate pharynx. Larynx develops from the caudal hypobronchial eminence, which later becomes the epiglottis and the cuneiform cartilages. Laryngotracheal groove is formed at the level of the sixth arch, and its opening is further developed to become T-shaped. On the sides of the T will be the connection of two arytenoid swellings. The arytenoid swelling later on become the arytenoid cartilages. The transverse groove forming the transverse bar of the T will form the array epiglottic folds and muscles together with the corniculate cartilages of the larynx. The laryngotracheal groove itself forms the respiratory tract. Its proximal end forms the trachea. The middle forms the bronchi, while the distal forms the lungs. So that's about the development. Now coming to the anatomy of pediatric larynx. You all know the anatomy of pediatric larynx is different from adult. So the newborn larynx is about 1/3 the size of the adult counterpart. The diameter of subglottis and glottis are narrower, which leads to an increased propensity for airway obstruction and compromise. The subglottic region in pediatric larynx is about 4 to 5 millimeters in diameter. The epiglottis is also narrower in infants. The larynx usually lies at the level of third or fourth cervical vertebra at birth. That is the lower limit, what I'm saying. By 15 years of age, it has descended to the level of the sixth cervical vertebrae. These dimensions leave little margin for obstruction in the infant, unlike the adult. The narrowest portion of airway in older child and adult, as we all know, is the glottic aperture, but the narrowest part of airway in infant is the subglottis. So a diameter of 4 millimeter is considered the lower limit of normal in a full-term infant and 3.5 millimeters in premature infant. Indeed, an infant with 1 millimeter of glottic edema will experience a 35% obstruction of the airway, whereas a subglottic narrowing by 1 millimeter leads to 60% narrowing. So what are the clinical manifestations of congenital anomalies of larynx? The mother will bring the child with respiratory obstruction or a stridor, a weak cry, dyspnea. Dyspnea is difficulty in breathing. Tachypnea, as you all know, is increased respiratory rate. The child may have aspiration symptoms, cyanosis, or even sudden death. The clinical presentation of each lesion varies from site. The majority congenital lesions present with symptomatology in the neonatal period or during infancy. The laryngeal lesions typically present with stridor, hoarseness, aphonia, and possibly feeding disorders. The stridor is usually inspiratory or possibly biphasic in nature. Stutter, on the other hand, is primarily caused by airway obstruction in the nasal or pharyngeal regions. Students, I would like to tell you the difference between a stridor and stutter. It's very important for you people to know the difference between stridor and stutter, because when a child or when a patient is coming to the emergency room, you should know whether the patient is in stridor or stutter, as the management differs. So stridor is nothing but a high-pitched sound, noisy breathing. It's a noisy breathing that is produced whenever there is a partially obstructed airway at the level of larynx, trachea, and or bronchi. Whereas stutter is a noisy breathing that is produced whenever there is obstruction at the level of nose, nasopharynx, or hypopharynx, oropharynx also. So coming to the supraglottic anomalies, I have classified the congenital anomalies of larynx according to the site. So we will see what are the common supraglottic anomalies, what are the glottic anomalies, and what are the subglottic anomalies. First, we will discuss about supraglottic abnormalities. So if if it would be a offline class, it would be easy for me to ask question about this image. So anyway, let me proceed. These are the two common congenital anomalies of supraglottis, but among the two, this is the most common supraglottic anomaly. In fact, this is the condition which is the most common cause of congenital anomaly of larynx. So let me proceed with this. The most common congenital laryngeal anomaly of larynx is laryngomalacia. So laryngomalacia as such is a very important topic because it's frequently asked question in your theory papers in Viva. So you should know about laryngomalacia. Laryngomalacia accounts for approximately 60% of laryngeal problems in the newborn. Boys are affected twice as often as girls. It's usually a self-limiting condition, but when severe, it may produce life-threatening obstructive apnea, cor pulmonale, failure to thrive. So fatal outcomes have also been described. Severe cases may require intubation or tracheostomy to secure the airway. So if you see this, this is the normal larynx. That's the epiglottis. That's the array epiglottic folds on either side. That's the arytenoid region. You can see the true chords, and that's the false chord. The whole thing here is supraglottis, and that's the glottic area. And below that will be your subglottis. So that's the normal larynx. This is during expiration, and this is during phonation. So what exactly happens in laryngomalacia? There is collapse of arytenoid mucosa. As you can see, there is collapse of arytenoid mucosa, shortened array epiglottic folds. It's almost a rudiment. If you see, array epiglottic folds are shortened, and you see a tubular epiglottis. It's also called omega-shaped epiglottis. That's the omega-shaped epiglottis. So what exactly happens is the supraglottic structures are pulled into the lumen around the vertical axis during inspiration. So the airway is narrowed. So the child will have difficulty in breathing whenever, or there will be noisy breathing whenever there is inspiration, or when it aggravates when the child will cry, as well as the condition aggravates when the child is in supine position. It is relieved in prone position. So a mother who is coming to emergency ward with a child or a newborn with a noisy breathing when the mother says that the condition worsens when the child will cry or when the child is in supine position, and the noisy breathing or that sound which is produced is decreased when the child is in prone position, you should be able to diagnose clinically with history itself that it's a case of laryngomalacia. So the condition arises from a continued immaturity of the larynx, as if the fetal stage of laryngeal development has persisted. The abnormality appears to be flaccidity or incoordination of supralaryngeal cartilages, especially the arytenoids, that is expressed when the infant is stressed by excitation with an increased respiratory rate. Stridor is typically noted in the first few weeks of life and is characterized by fluttering, high-pitched inspiratory sounds. Therapy consists of confirming the diagnosis by flexible laryngoscopy. That's the investigation of choice, I would say, rather, and reassuring the parents that the prognosis for the child is favorable. Position changes of the infant may help alleviate the stridor, as it typically worsens in the supine position. In the past, tracheostomy was the surgical procedure of choice for severe cases. Nowadays, it is supraglottoplasty, which has been proved very effective and very successful for the correction of supraglottic obstruction and is the surgical procedure of choice. Supraglottoplasty can be done using cold instruments or a coablator or a CO2 laser. So that's how the laryngomalacia larynx looks like. So you are trying to release the array epiglottic fold. That way, you're going to widen the laryngeal inlet. This is supraglottoplasty. Coming to another supraglottic anomaly, it's called laryngocele. So what is a laryngocele? Laryngocele is nothing but a dilated sac filled with air in the ventricle. You may have an internal or an external laryngocele. It may be present at birth. The child will usually present with stridor. It's actually difficult to diagnose. So I would like to say that you better to get an X-ray, AP and a lateral view. And you have to tell the child to do a Valsalva maneuver while taking an X-ray. That would be beneficial. How do you treat the condition? So if it is a minor problem, if the child is asymptomatic, I would rather say to regularly follow up. If it is quite big, if there is an external component, you can do an open approach, or if it is an internal laryngocele and if it is quite big, you can do endoscopic marsupialization. So recurrence rate are quite low in this condition. So that's the combined type. You can see the internal laryngocele and this is the external laryngocele. External laryngocele comes under the skin in the anterior and lateral part of the neck. It presents as a swelling in the anterior part of the neck. This actually laryngocele pierces the thyrohyoid membrane and comes and lies under the skin. So internal laryngoceles are within the larynx itself and they do not cross the thyroid membrane, whereas external laryngoceles penetrate the thyroid membrane at the neurovascular bundle. So mixed laryngoceles are dilated in both segments. So these are rare in infants. Laryngoceles are actually rare in infants and can cause intermittent hoarseness and dyspnea that increases with crying. This condition is quite common in blowers or who use saxophone or anything, something like that. So they have to use a lot of pressure glottic pressure. So that will actually have an impact on the thyroid membrane, and that may cause laryngocele, external laryngocele. Diagnosis may be difficult as these can contrast and may not be visualized under anesthesia. So a CT may be valuable in these instances. Sometimes if you can't make out in an X-ray with Valsalva, you can always get a CT contrast done. Endoscopic and open procedures have been advocated depending on the size and location of laryngocele. Coming to the glottic anomalies, the most common glottic anomaly is the glottic webs. Okay, these are webs. So laryngeal webs is because of failure of recanalization of larynx. So 75% of the glottic webs are situated or located anteriorly with subglottic involvement. You have 4 types of laryngeal webs with increasing severity. They may be present at birth. And again, the diagnostic investigation of choice will be of flexible laryngoscopy. Airway films helpful with subglottic extension. So the presentation of laryngeal webs varies with the severity and type of the web. Type 1 laryngeal webs involve 35% or less of the glottis. The true vocal cords are visible through the web, and there is little or no subglottic extension in type 1. So symptoms usually include a mild abnormal cry with some hoarseness. Respiratory distress is not a feature usually in type 1. Coming to type 2 webs, it involves 35 to 50% of the anterior part of the glottis. Subglottic involvement stems more from thick anterior webbing than from cricoid abnormalities. Airway symptoms are uncommon except during infection or after intubation trauma. So type 3 webs involve 50 to 75% of glottis. The web is thick anteriorly and the true vocal cords may not be visualized. They may be associated cricoid anomalies. Airway symptoms are often severe and marked vocal dysfunction may occur. Coming to type 4 webs, it usually occludes the 75 to 90% of the glottis. It is uniformly thick and the true vocal cord is not at all identifiable. The patient is aphonic and immediate airway management is required at birth. So coming to the treatment aspect of laryngeal webs, thin membranous type 1 webs which produce only minimal symptoms can be observed until age 3 or 4 years and then divided with either CO2 laser or coal knife. Type 2 webs can be managed by incising the web along one vocal cord and then proceeding with staged dilatations. Treatment of type 3 and 4 webs is usually delayed until the child is 3 or 4 years old. Most infants will have a tracheostomy or a tracheotomy in place for airway control until definitive surgery is undertaken. So the definitive treatment will be a laryngotomy and needle insertion. So coming to the second most common congenital anomaly of larynx, it's the vocal fold paralysis. So vocal fold paralysis has long been recognized as a significant cause of stridor and hoarseness in infants and children. It's the second most common cause of stridor in the newborn behind laryngomalacia. Laryngeal paralysis may be present at birth or may manifest itself in the first month or 2 of life. The neurologic impairment reflects an injury to the vagus nerve. So that's the picture. You can see that both the vocal cords are in the paramedian position, bilateral vocal cord palsy. That's the picture. The lesion can occur anywhere from the brain through the neck into the chest and into the larynx. Many paralyses are idiopathic in up to 47% of the cases. The most common causative factors include Arnold-Chiari malformations, hydrocephalus, neonatal hypotonia, multiple peripheral paralysis, that is myasthenia gravis. Other causes include birth trauma and cardiac anomalies. Associated laryngeal lesions such as laryngeal clefts and stenosis are also commonly associated or commonly found with laryngeal paralysis. Any or all of the normal laryngeal functions may be abnormal in pediatric patients with laryngeal paralysis. So the most common symptom with which the child is hospitalized or coming to the hospital is stridor, that is ineffective cough, aspiration, recurrent pneumonia, and feeding difficulties, which are reported. Consistent stridor, cyanosis, and apnea are frequent. Voice and cry, however, may be normal, particularly in cases of bilateral vocal cord paralysis. Hoarseness and dysphonia are common in cases of unilateral vocal cord paralysis. So the management depends on child's underlying condition. Children with bilateral vocal cord paralysis frequently require surgical intervention in order to secure the airway by means of doing a tracheotomy. The airway is often markedly compromised, and in over 50% of the cases, a tracheotomy is required. Multiple lateralization options include carbon dioxide laser cordotomy and open arytenoidectomy, arytenoidopexy, arytenoid suppression with cartilage grafting, or laser arytenoidectomy and cordectomy. The management of unilateral vocal cord paralysis in children is usually less urgent than that of bilateral paralysis. Children adjust well to persistent unilateral vocal cord paralysis with few sequelae. A weakened cry may result, but an adequate airway is the typical, its airway is typically maintained well in unilateral paralysis. Coming to the subglottic anomalies, the most common subglottic anomaly is subglottic stenosis. That's the picture of subglottic stenosis. You can see the narrowing of the subglottic region. So subglottic stenosis may be classified as either or congenital. Today we will be discussing on congenital stenosis. Although it is uncommon, it accounts for about 5% of all cases. It is the third most common congenital airway problem. That's after laryngomalacia and vocal cord palsy. Congenital subglottic stenosis is thought to be secondary to failure of laryngeal lumen to recanalize properly during embryogenesis. Subglottic stenosis is considered congenital if there is no history of endotracheal intubation or other forms of laryngeal trauma. Subglottic stenosis is defined as a subglottic lumen of 4 millimeters in diameter or less at the level of cricoid cartilage in a full-term infant. The normal newborn subglottic diameter is about 4.5 to 5.5 millimeters, and in premature neonates, it's around 3.5 millimeters. Congenital subglottic stenosis is divided histopathologically into membranous and cartilaginous types. Membranous subglottic stenosis is usually circumferential and it consists of fibrous soft tissue thickening. The cartilaginous type usually results from a thickened or deformed cricoid cartilage. The severity of congenital subglottic stenosis depends on the degree of subglottic narrowing. Children with subglottic stenosis usually present with stridor and or respiratory distress. Now coming to the classification. So how do you classify subglottic stenosis? There are 4 stages as described. You can follow a McCaffrey systems classification for laryngotracheal stenosis, or there's also a classification by Cotton-Mayer. Stage 1, the lesions are confined to the subglottis or trachea and are less than 1 centimeter long. Stage 2, lesions are isolated to subglottis and are greater than 1 centimeter long. Stage 3 are subglottic or tracheal lesions not involving the glottis, and stage 4 lesions involve glottis. Treatment of congenital subglottic stenosis is tailored to the symptoms and grade of the stenosis. Symptoms are typically less severe in congenital subglottic stenosis than in the acquired form comparatively. Congenital stenosis also improves as the child grows, and less than half of the children with this disorder will require a tracheotomy. For those children who do not require surgical intervention, several options are also available. So mild stenosis, Cotton-Mayer's grade 1 and 2, that is less than 70% airway, can usually be treated conservatively with observation. In cases that do require surgery, endoscopic techniques such as CO2 laser resection of a membranous web can be performed. Grade 3 or 4 stenosis may require some form of open surgical procedure, as these typically are the result of cartilaginous stenosis. So usually if there is a cartilaginous stenosis, it has to be resected, that is tracheal resection. Laryngotracheal resection with end-to-end anastomosis can be done. That has a better results. So coming to another subglottic anomaly, it's laryngeal cleft. This is the rarest of the congenital anomaly of larynx. It occurs in 1 in 2000 live births, less than 0.3% attributable to laryngeal cleft. So boys, again, are more commonly affected with a ratio of 5:3. Contributing factors. It's usually common in premature babies and in heteromnias. So the cricoid cartilage begins forming at 5 weeks of gestation and is derived from 6th branchial arch. So chondrification completes by 6 weeks of gestation. So if there is any incomplete fusion of tracheobronchial septum or cricoid cartilage, that will lead into laryngeal cleft or tracheoesophageal fistula. So how do you classify laryngeal cleft? Type 1 clefts as supraglottic interretinoid clefts. Type 2 clefts are a partial cricoid clefts. Type 3 clefts are a complete cricoid cleft with or without extension into esophagus. And type 4 are full laryngotracheal esophageal cleft. You can see the difference. 1, 2, and 3, 4. Partial and complete laryngotracheoesophageal clefts. This is how you classify laryngeal clefts. So how will the child manifest with a laryngeal cleft? There can be a choking, or there can be aspiration while feeding. There can be complaints of regurgitation. Child may be in stridor, or there can be recurrent pneumonia, chronic cough, and cyanosis. Coming to the treatment. The timing and approach for surgical repair again depends upon the severity of the symptoms, associated abnormalities, and the type of cleft. In small cleft, conservative positioning and thickened foot is advisable, and if this treatment fails, only then you can proceed with surgical repair using a gel foam injection or an open approach and graft interposition or an endoscopic approach. Anything can be tried. So to summarize, the congenital lesions of larynx or congenital anomalies of the larynx, the most common congenital anomaly of larynx is laryngomalacia. So the chief complaints with which the mother will bring the child to emergency room is noisy breathing, and it aggravates when the child cries or in supine position, and it is relieved in prone position. This condition usually starts by 2 or 3 weeks and it worsens by 6 months. And then gradually the symptoms come down and it can be self remitting by 2 years of age. This is the common scenario. But yes, this is in mild versions. If the condition is very severe, the child may have cyanosis, or the child may have failure to thrive, or apneic symptoms, or the child may have carpulmonale. So in that case, you have to do a surgical procedure called supraglottoplasty, which is the surgical treatment of choice. So this is in brief about laryngomalacia. This is something very important for undergraduates because it's been frequently asked in your theory papers and also in Viva. So coming to the next most common congenital anomaly, that's your vocal cord paralysis. So if it's bilateral, I would like to say that it's an emergency, it's an ENT emergency. You have to do a tracheotomy at the earliest. Okay, the investigation of choice to diagnose any pathology in congenital anomalies of larynx, the investigation of choice would be flexible nasopharyngo-laryngoscopy. Okay, the third most common congenital anomaly would be subglottic stenosis. Again, the child will have stridor and respiratory obstruction. Again, you have to do a flexible scopy, flexible laryngoscopy under local anesthesia, and then confirm your diagnosis and then treat the patient accordingly. So this is about congenital lesions of larynx. So we will come with some other topic in the next class. Until then, thank you.